Okay, thank you. Thank you, Pulish, for the introduction. So this is about the surgical options for rectal carcinoma. Before starting, we must know the anatomy of the rectum. Usually, the rectum is around 16 centimeter. It might vary according to the sex of the patient and the height of the patient. If we take it as a 16 centimeter, the mid rectum is below 12 centimeter. So the cutoff point between mid rectum and the upper rectum has implications in managing rectal carcinoma, because the upper rectal cancers are usually considered as colonic cancers. And one more thing is the anorectal junction for surgeon is at the level where the puborectalis sling comes around the anorectum. But for anatomists, the anorectal junction is at the dental line, somewhere here. But for us, it is at the anorectal, where the puborectalis sling is make a sling around the upper part of the anus. Again, the upper rectum has been defined variously by various societies. I was trying my best to include all the definitions, but you can take it as the rectum, the level of the rectum above maybe between 10 to 15 centimeter is called as upper rectum. So the option for rectal carcinoma resection, that is, you can operate only through the abdomen, which is called anterior resection. Another option is only through the perineum, where you can use various methods called TAMI, STEM, or DOE. Or it can be abdomen plus perineal, where you operate both from abdomen as well as you operate from perineum. Some of these procedures are sphincter saving, while APR is not a sphincter saving procedure. So this diagram, if you look at this diagram, we can understand all the type of rectal carcinoma resections. The line here, which is peritoneal reflection, where it's marked as PR, above this, if we do anastomosis above the peritoneal reflection, it is called high anterior resection. It is not the level of the resection, but the level of the anastomosis. We call it high anterior resection. So the anastomosis must be above the peritoneal reflection. We call it high anterior resection. So ultra low anterior resection is at the level of the anorectal junction. That is the surgeon's anorectal junction. So if you anastomose at the level of the anorectal junction level, we call it ultra low anterior resection. So the low anterior resection means between, if we do an anastomosis between the peritoneal reflection and the anorectal junction. So you call it low anterior resection. And let's say the tumor is even further low, distally towards the anus, then we can dissect between the external sphincter and internal sphincter and resect the tumor and try to do anastomosis below the anorectal junction. That is called intersphincteric resection. Intersphincteric means between both the sphincters. So anterior resection, the meaning of anterior resection is that we have to remove the part of the rectum as well as IMA has to be ligated. So see, like sigmoid colectomy means removal of resection of the sigmoid. So likewise, anterior resection means it is the resection of the rectum. At the same time, there must be a So inferior mesenteric artery can be ligated at the root of the IMA. That's called high tie, or it can be ligated distal to the left colic artery. This is the left colic artery. So if you ligate somewhere here, that is actually superior, this area, this part of the artery is called superior humeral artery. So if we ligate it here, we call it low tie. But low tie, if you are doing a low tie, we must always go up and remove the lymph nodes here, because these lymph nodes can become positive if you don't remove the lymph nodes if we are doing a low tie. There is one more thing, there's a thing called central vascular sparing as well. High tie will give you more length of the bowel, so you can go down a pelvis and anastomosis easily. But it is disadvantage is that the blood flow to the distal end of the colon where you are going to anastomosis will be less. So this is what we call a central vascular sparing. Probably high tie and low tie you all know. The central vascular sparing is we go and ligate the inferior mesenteric artery at the root, and we preserve the left colic artery and preserve the first branch of the sigmoid artery. But then we also ligate the superior humeral artery distal to the origin of the first sigmoid artery. So the blood can flow both ways, like this and along this marginal artery. So you all know this double staple anastomosis. Double staple means we put a transverse staple across the rectum and then anastomosis with the circular staple. And we can do the anastomosis either with staples or anastomosis or anastomosis. So these are some of the staples we use for open rectal resections. And these are the staples we use for laparoscopic rectal resections. So other concept is total mesorectal excision. Initially, it was advised to have a total mesorectal excision where the whole mesorectum must be removed. But after some time, some of the surgeons did what's called partial mesorectal excision. Partial mesorectal excision means you remove the part of the mesorectum, the 5 Sorry for the interruption. My internet went down. Hello.
Can hear you, Nusay.
So the partial mesorectal, yeah. So sorry, partial mesorectal excision means we remove the part of the mesorectum around 5 centimeter below the tumor. So when you are doing this, we must when we apply the stapler, we must remove the inside the mesorectum all around the rectum. Otherwise, you might find it difficult to apply the stapler. So usually this is done for upper rectal tumors. For mid and lower rectal tumors, we have to perform total mesorectal excision. So the rectal surgeries can be done either open, laparoscopic, or by robotic methods. In laparoscopy, we can do the total laparoscopic anastomosis with intracorporeal anastomosis, where we perform even the anastomosis inside the peritoneal cavity. But sometimes we can take the bowel out and perform the anastomosis outside. That is called extracorporeal anastomosis. So this is one method of doing laparoscopic anterior resection. This is one way of putting the ports. There are various, some surgeons use this port size slightly differently. And if you are doing an extracorporeal anastomosis, we have to take the specimen out through one point. We can either take through the umbilicus, where we can extend the umbilical port in a longitudinal manner and then put a Alexis port and then take the specimen out. Or we can take it through the left iliac fossa port, or even we can make a phalansteal incision and then take the specimen out. So I was talking about intersection. So it can be done by laparoscopic or robotic method, where we start a dissection from laparoscopy, from inside the hello. This is what I was talking about, the laparoscopic or robotic approach for interspheric resection. This is the rectum and this is the puborectalis and this is the this is a pubococcygeus, this is a puborectalis. So you dissect up to the pelvic floor and then enter between the rectal wall and the pubococcygeus, and we'll have to inside the puborectalis muscle somewhere here. And then you can dissect between this is the external sphincter and internal sphincter, and enter the intersphincteric space. So if you are doing the perineal approach, and you might remember how we do the lateral internal sphincterotomy, you can put a anal retractor and feel the intersphincteric space between the internal sphincter and external sphincter, and then make an incision here and enter the intersphincteric space. And this is what I was mentioning. You have to put a lone stack retractor and make an incision here between the external and internal sphincter and enter the space. And then we can incise here. Before the incision, we have to put a suture to close off the rectum. So if you look at this, which gives us a good idea about what we have to do in the lower rectal tumor. These are called early stages of lower rectal cancer. If the cancer is more than 1 centimeter from the anal rectal junction, obviously we can do ultra-low anterior resection. To do an ultra-low anterior resection, there must be at least 1 centimeter clearance. So if it is more than 1 centimeter, we can take a 1 centimeter clearance and do a ultra-low anterior resection at the anorectal junction. But if it is the tumor is at the anorectal junction, less than 1 centimeter, then we have to do what is called a partial intersphincteric resection. Partial intersphincteric resection means, as you know, the internal sphincter starts at the anorectal junction and it comes up to the anal verge. So what we do is we resect only the rectum and upper part of the internal sphincter. That is called partial internal sphincter resection. And if the tumor is even further below, what we have to do is we have to resect the whole internal sphincter and anastomosis at this level. So if you are removing the whole internal sphincter, it is called total intersphincteric resection. If you are resecting at the level of the dentated line, it's called subtotal intersphincteric resection. But if the tumor involves the external sphincter, some surgeons actually perform removal of the part of the external sphincter. You can't remove the whole of the external sphincter, but this is not recommended by many surgeons, even though some surgeons do this procedure. So, intersphincteric resection is a method to prevent an end colostomy. So, but we can't perform intersphincteric resection for all the patients. If the tumor is undifferentiated, we can't do the intersphincteric resection. For well differentiated or moderately differentiated tumors, we can do the intersphincteric resection. At the same time, if the tumor is involving the levator ani or external sphincter, then we can't do the intersphincteric resection. We have to do the abdominal perineal resection. And obviously, if there is a poor sphincter resection, we can't remove the internal sphincter. That will cause incontinence. So then we'll have to consider APR. And even some surgeons trying something called conformal sphincter preservation operation, where let's say the tumor is onto one side, they try to remove the tumor and the sphincter on one side, but try to preserve on the opposite side. So, traditional intestinal resection, they go straight across. Here, they they remove where the tumor is involved, or try to preserve the opposite side. This is called conformal preservation. But this also performed by some surgeons only. And now there's another new topic called transanal total mesorectal excision. In some patients, total mesorectal excision is difficult. Laparoscopically, it's very difficult, but there is a bit easy if you are doing with robotic resections. Mainly the male pelvis, they have narrow pelvis and advanced tumors with obesity. It may be difficult to do a ultra-low anterior resection or intestinal resection. So for this thing, there's a new technique called transanal transanal total mesorectal excision, where we resect along the mesorectum, either laparoscopically as much as we can, and then we make an incision through the anus and enter the intersphincteric space, and then dissect along the mesorectum and then go and meet the plane we have resected by the laparoscopy. For TATME means transanal total mesorectal excision. To do this, we can use the single incision laparoscopic port, or there's something called gel point. This is custom made for the TATME. Or the poor surgeons, they can use a Alexis port. You know, Alexis port where we used to remove the specimen from the abdomen after laparoscopic surgery, and then tie a glove to it, and then put the scope and then the instruments and the insufflator through these fingers of the gloves. So this is how we do the transanal TME. We identify the tumor and then put a purse string distal to it, around 1 centimeter distal to it. So there won't be a tumor spillage. And then we make an incision, maybe with we mark it first initially with the hook, diathermy hook. Then we make a full thickness rectal incision all around it with the available in the ultrasonic dissector or any other dissectors. And then we dissect it upwards, and then we meet the plane which has been created by the laparoscopy. So there's some other techniques we use to remove excise the early rectal cancers. One of them is called TAMIS. TAMIS means transanal minimally invasive surgery. We can use the same ports which we are using for TATME, and then use the same instruments and inside rather excise the early tumors. Mainly this is done for T1 tumors, and rarely you can do a small you can excise small T2 tumors as well. And you can do this in all the positions. If the tumor is according to the tumor, you can position the patient where it will be easy for you. So this is how we do it. This is the TAMIS procedure, and the monitor is being kept between the legs on the head end of the bed. So there are complications of FAMIS, but they are not very serious. They are not very common. And other thing is that as surgeon, we usually perform the traditional method of transcranial excision. But the problem here is we can't reach more than maybe 7 to 8 centimeter or sometimes 6 centimeter. So if the tumor is around 10 centimeter, we can excise it transcranially. But if we lower than that, 6 centimeter, maybe 6 centimeter or something, we can mark the tumor around, we can mark the mucosa around the tumor with diathermy, and then we can even do a full thickness resection and then suture the bowel wall. But the problem may be that we may not be able to remove the or excise the tumor on block. We might sometimes, the high chance that we might fragment the tumor. There's some procedure called IPF procedure, that's also for rectal cancer excision. And then APR, if we try, we can try low anterior resection, intersphincter resection, TATME, but if those are contraindicated, last resort will be APR. So APR, we must be careful because when we are doing laparoscopy anterior resection, we comes along the mesorectum and then enter this plane, medial to the levator line. But if when we are doing abdominal resection, we must always come close to the, we must remove the levator as well. So if we go here, we may be too close to the tumor and the margin may be positive. So this is called extra levator anterior abdominal resection. So the plane must be here rather than here. This plane, when you are doing low anterior resection or ultra low anterior resection or intersphincter resection. Even APR can be done, the abdominal approach can be done by open laparoscopic or robotic method, and then the hernial approach as the traditional method. And even some people are trying to make neo-sphincter because some patients don't like colostomy, so they're trying to make neo-sphincters. So the surgeons are trying to make sphincters with gluteus maximus or gracilis with varying success. Also, some of the surgeons are trying artificial anal sphincter. This is after doing APR. So the patients don't like colostomy, so they're trying artificial anal sphincter. This also has various successes. So after APR, there will be a wound in the perineum, and the healing of this is very much less, and the healing will be even low if there is if there was irradiation to the perineum. So sometimes you can try to close the defect with muscle flaps, either rectus abdominis or gluteus maximus muscles. Other thing is some surgeons even use the biological measures to put for the pelvic floor so that the perineal surgical options for locally advanced rectal cancer. Here I'm talking about T4B. T4B means it is involving another organ. So this is a bit of a serious condition. And if you are considering surgery for a locally advanced rectal tumor, that is T4B, we must make sure there's no metastasis anywhere else. and we must be able to do a R0 resection, or if we are doing an R1 resection, it must the remaining tumor in the body must be very minimal so that we can give intraoperative radiotherapy. So if the tumor extends posteriorly, and if it involves the presacral fascia, we can excise the presacral fascia. Usually we go, when you are doing a mesorectal excision, we go between the mesorectal fascia and presacral fascia. And if the presacral fascia is involved, we have to excise it. And if it is involving the sacrum, we have to excise the sacrum. But usually we try to preserve the S2 because the bladder and sexual functions are dependent on S2 nerve. So maximum we remove is below S2, S3. But if we are doing this, if we are doing this type of surgery, we must have all the other surgeons like orthopedic or plastic surgeons involved in this surgery. So other thing is pelvic excenteration. Again, this is for T4B. T4B means it involves adjacent organs. So let's say if the tumor is involved in the bladder, you can, if the part of the bladder is involved, you can remove the bladder and then excise it. But if you have to remove a large area, then you might have to remove the whole bladder and make a neobladder with a small bowel, or you can make a ileal conduit. But again, this has to be done with the urologist. So after ultra-low anterior resection, some of the patients develop anterior resection. So this must be anterior resection syndrome. Anterior resection syndrome. So to minimize this, there are few ways which has been tried. You can do rather than doing an end-to-end anastomosis, you can do a end-to-side anastomosis. You don't anastomose here, you anastomose somewhere here. Or you can make a pouch, J pouch, where you make a 5 to 8 centimeter pouch and then anastomose to the inner canal. Usually the research says that the level of incontinence or the urgency is low at the initial period only. After some time, even if you do a J-pouch anastomosis or a direct end-to-end anastomosis, the level of anterior resection syndrome will be less. It will be same. So other thing is FAP and rectal cancer. FAP, we know we have to remove we have to do a proctocolectomy with either ileal anastomosis or restorative proctocolectomy. So if there's a rectal cancer, you'll have to do the same thing again. You have to do either proctocolectomy with endoileostomy or restorative proctocolectomy with pouch formation. Obviously, we can do a total colectomy and ileorectal anastomosis if there is a tumor. So one of these two will be the option. There is somewhat a new concept which is called organ preservation. That's a preservation of the rectum, where we give the oncologists give chemo radiation before the surgery, and then again restage the tumor and do radiological investigation and see what has happened to the tumor. If the tumor has completely disappeared in MRI or EUS or even endoscopy, they follow watch and wait policy. Rather than operating on them, they follow up and see what happens. If the tumor recurs, they bring the patient back and then operate. But this is not performed by all the units though. But there are some difficulties like whom we are going to follow up. So then there are endoscopic methods to detect early rectal cancers like submucous resection or submucous resection. Yeah, the tumors are resected or dissected along the submucous plane, or there's something called endoscopic full thickness resection, where the full thickness, the rectal wall can be dissected with a new gadget, which is used through the endoscopes. And resectable metastasis, we all know that the metastasis in liver and lung can be resected. And there is one more. Hello. Sorry, there's a power cut here.
We can see your sides.
Okay. Sorry, there's a power cut here. I'm struggling a bit. So the whole procedure will be done through the vagina, where even the ligation of the inferior mesenteric artery, inferior mesenteric vein, everything will be done through the vagina, and the specimen also will be removed. And obviously, in transfemoral, you can understand it will be done in males and females. Same way, you make a incision, full thickness incision around inside the rectum, and then go inside and remove whole surgery. Okay. And then you must know about when we do fecal diversion, probably we all know, like in male patient, when there's malnutrition, old age, and prior radiation. Kulisha, I think that's all. I'm struggling here a bit without the power. I have power cut here.
All right.
Hello.
Yeah. We can hear you.
So
You can see the slides.
can you bind up? Yeah.
Yeah, sure. Yeah. There are no questions. So
Okay.
shall we stop here?
Okay, that's fine. Yeah.
Yeah. So I want to thank Dr. Nusair for this excellent presentation and sharing his experience. Thank you, Nusair. And thank
Okay,
you for all of you that joined the webinar today. Good evening.
Okay, thank you very much.